Well, I've got a headache. That's no fun. So this is that when we're looking at headaches, the first thing to always exclude is you must exclude evil things first. You must exclude mass things like tumors. Well, people who have tumors tend to have focal neurological problems. They tend to have papillary edema. Not that anybody looks at eyes anymore. And these things are not recurrent episodes that get better and go away for a while, then come back 3 weeks later or 4 weeks later. People who have tumors, they have headaches. The headaches don't go away. They get worse and worse and worse and worse, and they keep vomiting. They have focal findings, papilledema, and vomiting over time, and it doesn't get better. It does not get better. So subarachnoid hemorrhage is going to be very sudden, and it's going to look like the sudden onset of meningitis with a stiff neck. Photophobia, Koenig's and Brzezinski's sign, not that I can remember which one either one is, like the sudden onset of headache, sudden onset, all of a sudden I ruptured my berry aneurysm in my circle of Willis, and I have severe sudden headache with fever, headache, stiff neck, photophobia, Koenig's and Brzezinski's sign. People who have temporal arteritis, also known as giant cell arteritis. People who have temporal arteritis or giant cell arteritis, they have tenderness. They have tenderness over the scalp, tenderness over the temporal area, and they have visual problems because this stuff starts to damage their ophthalmic nerve, their ocular nerve, their ophthalmic artery. They damage the ocular artery, temporal arteritis. And this is a big deal. By the way, this is unique amongst the headache syndromes of being most characterized by tenderness on the scalp. So in order, before I get on to things like migraines, cluster headaches, and tension headaches, I must first exclude something that's very dangerous as an etiology of headache. A guy comes in and he says, "Doc, I got a very severe headache. It won't go away." Is this your first episode? Yes. Maybe he's going to turn out to have migraines. Maybe he's going to turn out to have cluster headaches. Maybe he's going to turn out just to have a tension headache. How do I know it's not a tumor or subarachnoid or something worse? Tumors are associated with focal findings, nausea, vomiting, and they don't get better because your tumor doesn't get better. As the intracranial pressure worsens, the tumor headache worsens. The nausea and the vomiting worsens. The papilledema doesn't worsen, but all of it gets worse and worse and worse over time. "Doc, I got a terrible headache." But do the lights bother your eyes? If the lights bother your eyes, it's time for a head CT fast to look for subarachnoid hemorrhage. So let's see first, before you get on to migraine, clusters, and tensions, let's first exclude evil things. Now, meningitis, what's the difference between this and subarachnoid hemorrhage? Subarachnoid hemorrhage is very sudden, and subarachnoid hemorrhage, what is different, what's unique? 50% of people with a subarachnoid hemorrhage have a loss of consciousness. 50% of people with a subarachnoid hemorrhage have a loss of consciousness. 50% of people with a subarachnoid hemorrhage have a loss of consciousness. So that 50% with the loss of consciousness is because the subarachnoid hemorrhage is a sudden rupture of an aneurysm in the berry aneurysm in the circle of Willis. When there's a sudden loss of blood into the intracranial space, what happens is that intracranial pressure, does it go up or does intracranial pressure go down? Intracranial pressure should go up because I have bled into my brain. When I bleed into my brain and I have increase in intracranial pressure, this sudden loss of vascular integrity with its sudden increase in intracranial pressure provokes a sudden decrease in cerebral perfusion. Because how can I perfuse my brain if I have no sufficient blood pressure to get the blood up in here. Cerebral perfusion is based on the fact that the pressure here in the heart is greater than the pressure here in the head. Like pumping water up to the top floor of a house. The pressure has to be greater here than up here, so the water will go up. If you have a sudden bleed, the pressure in here goes up and perfusion goes down. So you have a sudden loss of consciousness. Now, meningitis looks exactly the same, except meningitis will not give you a loss of consciousness. It looks like subarachnoid, the sudden onset of meningitis with loss of consciousness. The sudden cause of meningitis with a loss of consciousness. Now, the initial test for all these here, let's see, guy comes in with a tumor, got a CT scan. The person who comes with a subarachnoid, the CT scan. Let's look at this one. We have a 35-year-old guy that comes to the emergency department. He is complaining of a severe headache. He is complaining of a severe headache. He's got tenderness of his temporal artery, and visual disturbance. What would you do next in the management of this patient? You got a 35-year-old guy who's got a headache. He's got a headache and he's got tenderness over his temporal area and he's got visual disturbance. What would you do next? What is the most appropriate action, step, do, management? Action, step, do, management. ¿Qué tú quieres ahora, papito? And the answer is steroids. If it gives you the choice of choosing between steroids and ACT, you are going to choose the steroids first. You will choose the steroids first. If they give you a choice of steroids or a CT scan, they are going to ask you to choose steroids first. Why? Because it is better to give the steroids for a few days while waiting for the temporal artery biopsy. While waiting for the temporal artery biopsy, which is the most accurate test. Most accurate test. Which of the following is the most accurate test? A biopsy. It's better to give the steroids for a few days while waiting for the results of biopsy than to wait for the results of biopsy and go up to the patient and say, we've got the results of your biopsy right here. Where? Right here. Where? Right here. I don't see it. Why don't you see it? 'Cause I'm blind. It's better to give the steroids than wait to see whether you have to get your biopsy report translated into Braille. So give the steroids and wait for the biopsy later, or you have to have the biopsy report in Braille. So steroids is first, biopsy is best. If you do CT and wait for results of the biopsy, you will become the best doctor at the Lighthouse for the Blind. This is the major thing that you come here to learn for step 2, the order in which to do things. You've heard of CTs, you've heard of biopsies, you've heard of steroids, but what's the next? What's the next? What's the next best step? Now, the CT scan for subarachnoid hemorrhage is going to be 90 to 95% sensitive. It's going to be 90 to 95% sensitive. As a test that is 90 to 95% sensitive, you don't have to do the lumbar puncture in the vast majority of people. You only have to do the lumbar puncture in the 5% that have a false negative CT. In other words, if your CT scan is negative, you can do the lumbar puncture to make a diagnosis. Now, if the lumbar puncture shows red cells, it will also show white blood cells. If the white blood cells are up, how do you know whether those white blood cells are up because there is an infection, because meningitis causes headache? How do you know whether the white cells are up because it's an infection? Or how do you know whether the white cells are up simply because there is blood in the cerebrospinal fluid? You see, blood in the cerebrospinal fluid makes the white cells go up. Blood in the cerebrospinal fluid makes the white cells go up. How do you know whether the white cells are up because there's an infection or whether simply because this is a dilute CBC? And the answer is, if there's an increased ratio of white cells, normally there's one white cell for every 500 to 1,000 red cells. Well, what happens if you have 50 white cells and only 1,000 red cells? Well, that's far too many white cells to be accounted for by just this number of red cells. 1,000 red cells should only give 1 or 2 white cells. 1 or 2 white cells. But if you have 10,000 red cells, well, then you should be having 10 to 20 white cells. But if you have 100,000 red cells, then 50 white cells is not a problem. If it's 100,000 red cells, because this would just be a dilute CBC. If the ratio is greater than the normal proportion, which is about the 1 white cell for every 500 to 1,000 reds, if the ratio of white cells is greater than 1 white cell for every 500 to 1,000 reds, then there is infection. The treatment for the tumors is surgical removal, radiation, chemo, surgical removal, radiation, chemo. But the best initial therapy is dexamethasone to decrease intracranial pressure, to decrease the swelling around the tumor while waiting for the results of the biopsy, which is the most accurate test. Biopsy is the most accurate test. The treatment for a subarachnoid hemorrhage. The treatment for a subarachnoid hemorrhage is to do an angiogram. And you say, that's not a treatment, that's a test. That's not a treatment, that's a test. Well, the angiogram allows me to know where you bled from. The angiogram allows me to know where did you bleed from. Where is the site of anatomic defect? The angiogram allows me to know where did this happen from, man? I don't need an angiogram to diagnose a subarachnoid hemorrhage. That's true. I could diagnose a subarachnoid hemorrhage off the head CT and off the lumbar puncture. I don't need an angiogram to diagnose a subarachnoid hemorrhage. I can diagnose the subarachnoid hemorrhage off of a CT or an LP. I need the angiogram to determine the site of surgical cleaning it up, surgical clipping or embolization with a catheter. I need the angiogram to determine where will I surgically place the clip so it doesn't rebleed. If you rebleed, 50% of the people who rebleed die. So I don't need the angiogram to tell me you've got a subarachnoid. I need the angiogram to tell me where is that subarachnoid, where, so I know where to clip. Coronary artery disease. I don't need for coronary artery disease. I don't need for coronary artery disease to know with the angiogram that you got coronary disease. I could do a stress test. I need the angiogram to tell me whether you have 3 vessel disease or left main disease to tell me whether to do surgery. I don't need an angiogram to diagnose renal artery stenosis. I could do captopril nuclear renograms, magnetic resonance angiograms, duplex ultrasonogram to determine the presence of renal artery stenosis. I need the angiogram before I do angioplasty and place a stent. Before I do angioplasty and placing a stent. I don't need the angiogram to make a diagnosis of renal artery stenosis. I need the angiogram to determine the anatomic location so I can do angioplasty and placing a stent. So I can do angioplasty and placing a stent. You know, for the peripheral arterial disease, I don't need to do an angiogram to determine whether or not you have peripheral artery disease. I could do ankle brachial indexes, and look for a decrease in ratio greater than 0.9 for ankle brachial index. I do the angiogram to know where am I going to bypass? Where do I do surgery? Where do I do surgery? Where do I bypass? Where do I bypass? You know, I don't need to do an angiogram to diagnose carotid stenosis. I can do a duplex sonogram to diagnose carotid stenosis. I do an angiogram to determine the diameter in order to guide end arterectomy. End arterectomy. Peripheral arteries, carotid arteries, coronary arteries, renal arteries. I use the angiogram to guide surgical repair. I don't need to do an angiogram to diagnose a subarachnoid hemorrhage. I use an angiogram to diagnose surgical repair, which in this case is to put in a clip before you rebleed, because if you rebleed, you die. We use nimodipine, and nimodipine is a calcium channel blocker that decreases the risk of stroke. Nimodipine is a calcium channel blocker that decreases the risk of stroke. We use nimodipine to prevent vasospasm to decrease the risk of stroke. And the last thing for a subarachnoid is, if there is hydrocephalus, we put in a ventriculoperitoneal shunt to drain the hydrocephalus. Subarachnoid blood drains out of the subarachnoid granulations, like my hair in a bathtub drain. And my hair goes into the bathtub drain and clogs it up. Blood goes into your subarachnoid granulations and clogs them up and causes hydrocephalus. If I get hydrocephalus, shunty, shunty, shunty. Oh yes, shanti, shanti, shanti. Aram se krupya. Huh? Shanti, 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 Johnny man. No, shunt, shunt. Should we get shanti with a shunt? Oh, that's a good name for a shunt. The shanti shunt. Put a hole in your head and it makes you feel peaceful and relaxed. The shanti shunt. That's excellent. I love that. That's fantastic. Oh, bahut acha. Fantastic. You get a shunt. So the good news is that everybody who gets a bad subarachnoid, get hydrocephalus, gets a shunt. The bad news is you don't necessarily get shanti. Surgery, nimodipine. Let's look at the next slide. Okay, primary headaches are recurrent. Primary headaches are recurrent. In other words, tumors. People go like this, oh, primary headaches, bad, they're recurrent. See where it says primary headache, usually recurrent? People go, oh, that's bad, they're recurrent. That must be bad, it's recurrent. They keep coming back and back. Well, tumor is not recurrent. Is that good? No, because you die. The reason, you see, you have to be alive long enough to have something recurrent. You know what I mean? It's like gunshot wounds to the head. You go, listen, look on the bright side. It's not going to happen again. Okay? Secondary headaches. Okay? Severe and sudden and severe. That's talking about the subarachnoid. Accompanied by worrisome signs. I like this. That's welcome to my editors. Worrisome signs. Yes, a worrisome sign. So what was that worrisome sign? What was worrisome? Worrisome, worrisome. Oh, you mean when the guy had syncope and he drove his car into a telephone pole? Yes, that was worrisome. Or how about this one, when the person went blind? Yes, that was worrisome. That was a worrisome sign. Oh yes, here in the tumor when the guy had a seizure on the subway system and fell under a train and got run over. Definitely, I found that quite worrisome. Yes, so I want to say that these are some very worrisome signs and symptoms here. And I hate it when people have syncope while they're driving down the opposite lane of traffic from me. From me. Boom. Yes, that was worrisome. Yes, it's worrisome. You're going to die. Okay, let's look at the thing here. Intracranial hemorrhage, worst headache of my life. Beware of this phrase, worst headache of my life. Beware of that. What's the worst headache in your life? It's always the one you're having right now. Okay? In reality, it's been studied, and although this phrase is out there, worst headache of my life, I really prefer that you say worst headache of my life. Let's look up, associated with sudden loss of consciousness, sudden onset of meningitis, loss of consciousness, sudden onset of meningitis, and the worst headache of my life. A tumor. Well, the thing is, the pain is so bad it can wake you up, but also remember, which of these things here can present with a seizure? Which can present with a seizure? All of them. Tumor, trauma, infections, bleeding can all present with a seizure. Now, the first thing to do is to CT scan, CT, Only if there's temporal artery tenderness will you biopsy. Only if there's temporal artery tenderness will you biopsy. Only if there's temporal artery tenderness will you biopsy that temporal artery. So, but it's the same thing as seizures. Remember we said in seizures, when do you do an EEG? When do I do an electroencephalogram? I've excluded hypoxia. I've excluded calcium. I've excluded magnesium. I've excluded sodium, hypoxia, glucose, and toxins. I've excluded intracranial mass lesions by CT scanning the brain. I excluded all those things, and they're still having seizures. Electroencephalogram. Electroencephalogram. The same thing here. Once these things have been excluded, then you go and you say, oh, well, I excluded these things. Now let's look at the other forms of primary headache syndromes. I've excluded all this stuff. Now the question is this a tension headache? Well, tension headaches are bilateral and band-like. Tension headaches are bilateral and band-like. Tension headaches are bilateral and band-like, going around my head like somebody wrapped a belt around my head. Somebody wrapped a belt around my head and squeezing my head. Oh, yeah, squeezing my head. Yeah, squeezing my head. Yeah, squeezing my head. Oh, I'm squeezing the cameraman's head. I'm squeezing his head. Band-like around the brain. Band-like around the brain. But ready, look up, up, ding, 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 ding. There's no focal findings. You see focal findings, ain't tension headache. Focal findings are evil. Not semi-evil, not quasi-evil, not the margin of evil. No focal findings. No stiff neck. No stiff neckness. No neck stiffness. No aura. No aura, no focal findings, and you know what? No seizures. The reason is that we don't know what causes tension headaches. Oh, I'm sorry. I shouldn't say it like that. I should say you don't know what causes it. I'm an expert. What makes me an expert? Because I have deeper ignorance than you. If I want to screw around with you, I say, you don't know. And you'd be too chicken to say, well, Conrad, do you know? You have to be too chicken to say that. I can keep going like this. You don't know. But if you ask me, do I know? Then the answer is no. How do we go from being ignorant to an expert in 15 seconds? Ignorant, I don't know. Expert, nobody knows. Medical school professor, the data is not conclusive. Ignorant, I don't know what causes tension headaches. Expert, it is not known. Research scientist, the data is inconclusive. All different ways of saying, I don't know. Migraine. Migraine comes from the original Latin for hemicrania. Hemicrania, half a head. Hemicrania, half a head. And that is because these were unilateral 50% of the time. They were unilateral 50% of the time. Sometimes it can be associated with an aura. Sometimes it can be associated with visual problems, visual spectra fortification. One of my favorite words, spectra fortification. You ready? Somebody a long time ago said that if you look at, it's like in Monet paintings, Monet's years at something something. He said, this looks like the mist ascending over the battlements of a castle into the distance. Up ahead in the distance, I saw a shimmering light. Visual spectral fortifications. To the 19th century man who described it, he said what the person with migraine gets looks like a castle in the distance, with the sunlight coming over the clouds of the castle's battlements, spectra of the fortifications. Man, I don't know, but I love the poetry in that terminology. You know what I mean? I love the poetry. Spectra fortification. Looks like a castle in the distance. visual problems, smells as an aura, abnormal smells. Sometimes the migraine can actually cause focal neurologic findings. What's it called when you have focal neurologic findings in a migraine? When you have a complicated, it's very complicated like that. That's pretty complicated. When it's complicated by focal neurologic findings. When it's complicated by focal neurologic findings, what kind of migraine is that called? When it's complicated by focal neurological findings, what kind of migraine is that? That's a complicated migraine. Yeah, it's complicated. Why'd you have to be so constipated? Complicated. Okay? So the answer is complicated migraine means that there's such vasospasm that it actually causes a stroke. Yucko, man. Visual problems can be focal. Can be focal. You see, we're not really sure what causes a migraine. We used to think that migraine was caused by a vasospasm, followed by vasodilation, and in the vasodilation, you get the headache. We're not sure what causes it. However, you know, that's really a great mechanism for thinking about the drugs, because even though we don't know what causes it, it does underlie why beta blockers and calcium channel blockers are effective prophylactic therapy. Because even though we don't know what causes it, if this is vasospasm, followed by vasodilation, beta blockers and calcium channel blockers prevent the vasospasm. Cluster headaches. Cluster headaches are unique. Cluster headaches are unique because they are 10 times more common in men. They are associated, they're exclusively unilateral. It is like an ice pick being stuck into your eye. You know, I'm an attending physician at the largest city hospital in New York, the largest municipal hospital, Kings County Medical Center in Brooklyn, SUNY Downstate, where I'm Associate Chief of Medicine. And we were talking about cluster headaches one day, and just as we were there, a man came by, was coming into the emergency room, and he was complaining of a terrible headache. And I said, quick, go over there and ask that man what it feels like. And because we had just finished this discussion. And the guy, it was a man, he said, I have unilateral, sudden, severe pain. It was associated with tearing, rhinorrhea, because tears go into the duct, so that is the rhinorrhea, a red eye. And I went, oh my God, we've just diagnosed cluster headaches. Unilateral, it's a man, unilateral, tearing, rhinorrhea, redness in the eye. We've diagnosed a cluster headache. I said, the main thing will be like this. Ask the man what he feels like. And the student runs in and goes, because I say if it's a cluster headache, he's going to say it feels like an ice pick being stuck in my eye. The student runs in, he runs back, he goes, the man says it feels just like an ice pick being stuck in his eye. I'm like, it's a cluster headache. We should give this guy quickly, give him 100% oxygen, because this is the therapy for this 100% oxygen. We can use a triptan for abortive therapy. We can use ergotamine for abortive therapy. We can use things like lithium and steroids for chronic suppressive therapy, with lithium and steroids for chronic suppressive therapy. And I'm all set to run in there with the oxygen and the triptans and the ergotamine. And I said, are you sure it feels like an ice pick stuck in the eye? And the student said, yes, it does. And I walk into the man, and I see a man who's got an ice pick stuck into his eye. Well, that goes to show us that when a patient says, Doc, I feel like I've been hit in the head with a hammer, you should actually ask, well, have you been hit in the head with a hammer? Doc, it feels like I've been run over by a bus today. You should actually ask, well, have you been run over by a bus today? And the same with ice pick-like headaches. Now, on our next slide here, what we see is migraine headaches. This word pulsatile is very nonspecific. Throbbing is very nonspecific. It's true, pulsatile and throbbing. However, the big issue is this, is that they are unilateral migraines most of the time. That's what the word originally meant, hemicrania, half a head. However, they can be bilateral. Now, this thing about tension headaches where it says band-like, that's very important because tension headaches are band-like. They feel like a belt around your head. And it is associated with neck muscle tension and all these things, but it's still very difficult to be precise. Cluster headaches, this is very important. They're incapacitating. The person can't move. One-sided, incapacitating. And the other thing about cluster headaches is that the rhinorrhea is from the lacrimation. The lacrimation causes the rhinorrhea. The red eye causes the lacrimation causes the rhinorrhea, and the rhinorrhea causes the nasal congestion. You see, when you have a red tearing eye, it goes into the puncta, which drains into the nose, that causes the rhinorrhea. So that's the other thing about clusters. Clusters last a short amount of time. They last 20 to 90 minutes each. They go away, you have several episodes, and they go away, and they come back the following year. You could have them for 3 or 4 weeks at a time, 2 or 3 times a day, 4 or 5 times a week. They happen 10, 20 times over a few weeks, and then they're gone until they come back the following year. Remember, the single biggest thing is this: unilateral, ice pick, excruciating, red eye, rhinorrhea, tears. Now, migraines, most of the time, most of the time, 70 to 80% are unilateral, can be bilateral. Visual problems, flashing lights. Visual problems also get flashing lights and other ocular and visual disturbances. Spectra fortification, misty castles in the distance. And if it causes complicated, means that the vasospasm is so severe that it can actually result in a stroke, it's a complicated migraine. So let's look at treatments for a second. And here we have a CT scan of a person who's got a subarachnoid. You see this white stuff I'm looking at here? Well, white stuff over here might be okay if it's choroid plexus. But this white stuff through here, this is blood in the subarachnoid system. That's blood in the subarachnoid system. So this is a CT scan of the head showing the blood. Remember that the CT scan for subarachnoid is 95% sensitive on the first day. You lose about 5% of sensitivity each day because the blood reabsorbs, the blood lyses. And as the blood lyses, you lose the ability to detect the subarachnoid hemorrhage on the CT scan. So therefore, as the blood reabsorbs, you lose the ability to detect the blood on the scan because the blood lyses and it disappears. The blood lyses and it disappears. So therefore, 95% sensitive on the first day. Now you may notice that this thing is a CT scan, that this blood is here in the CT scan. Now, the MRI is a better test for almost everything else. The MRI in neurology, let's look at the MRI for a second. The MRI for multiple sclerosis, better than a CT. The MRI for a stroke, embolic stroke, much better than a CT. It's visible 95% to 24 hours. The MRI, much better at looking at the cerebellum and looking at the posterior fossa. Much better than looking at the cerebellum and the posterior fossa. The MRI is in fact better for everything except blood. It's better for everything except blood. It's better for everything except blood. When you're looking for blood, it's a CT. When you're looking for blood, it's CT. Subarachnoids and trauma. Subarachnoids and trauma. Now, let's look at this extraordinarily important slide here. Abortive therapies. In other words, doc, I got pain now. Non-steroidals and acetaminophen for mild pain. Triptans for severe pain from a migraine or a cluster. Ergotamine derivatives for migraine, headaches, or a cluster. In other words, abortive means I have pain now. I got pain now. Prophylactic treatments is that a person gets recurrent episodes of headaches. In other words, the treatment for migraines and the treatment for cluster headaches has enormous overlap. What do they both have in common? Both migraines and cluster headaches can be treated with a triptan acutely. Now you notice that we say triptan. We don't say sumatriptan, zolmitriptan, this a triptan, that a triptan, because the difference in efficacy is none. And anybody who says they're different is selling something for a drug company. So any of the triptans is okay. Migraines is probably, maybe caused by vasospasm, caused by vasodilation. When the vasodilation occurs, you have the headache. Vasospasm can be so bad as to cause a stroke, a seizure. Vasodilation and the headache. Professional neurologists then turn around in the next sentence and go, well, that's not really the mechanism. Except all the therapeutics is based on that mechanism. Vasospasm, followed by vasodilation, then the headache. Triptans constrict the cerebral blood vessels. Ergotamine constricts the cerebral blood vessels. So these pains get better when giving drugs that cause a vasoconstriction. These headaches get better. Decrease the pain. Oh, cool. What do you think the most common adverse effect of these? In whom are they contraindicated? Coronary artery disease. Why? Because in coronary artery disease, you don't want vasospasm, do you? I don't. Coronary disease, you want vasospasm? I don't want vasospasm. It causes vasospasm. Uh-oh. That's bad. It causes vasospasm. So the problem is that it causes vasospasm, and that's good for your headache, but it's bad for your coronaries. Now, these drugs, are these useful in tension headache? And the answer is no, because a tension headache is an idiopathic, not vascular headache. These are for vascular types of headache. And migraines and clusters, migraines for sure, clusters probably, are some form of vascular headache. What does vascular headache mean? Vasospasm followed by vasodilation and the pain. For mild headaches, non-steroidals for both of them. But that's for all of them. That's headache in general. Non-steroidals, and that's even here too in tension headaches. That's even here too. Now, the point of difference is that cluster headaches get 100% oxygen as abortive therapy. 100% oxygen as abortive therapy. Now, here's the next question. What happens when you're having more than 3 to 4 of these bad boys per month? Well, when you're starting to have a lot of these bad headaches every month, man, I wouldn't do that. They're incapacitated. We are talking about some very serious pain here. Very serious pain. Incapacitating pain. Excruciating, life-changing, crippling discomfort. I wouldn't even let people go 3 to 4 times. It's once a week. How'd you like to be taken out of action for 4 hours once a week? Boom! No way. No way. Prophylactic therapy. Prophylactic therapy. Beta blockers like propranolol. Propranolol as a prophylactic therapy. That's the #1 prophylactic therapy. Calcium channel blockers, SSRIs such as Prozac. Calcium channel blockers, SSRIs, okay, tricyclic antidepressants, phenytoin, and other seizure meds. These are definitely second line. #1 prophylactic medication is propranolol. Propranolol, okay? It's propranolol. Now, what's different about clusters is that for prophylactic treatment, lithium and steroids can work. Why do lithium and steroids work? Well, they work based on the same mechanism of cluster headaches. And what's that? I don't know. How do they work? I don't know. Why do you get a cluster headache? I don't know. Why is it in men only? I don't know. Man, you are so damn ignorant. I thought you were like a medical school professor. No, but I play one on TV. Wow. You know, we've done so many standardized patients for Step 2 CS, we've decided to come up with standardized faculty. And the answer is, what causes these things? The answer is, of course, obvious. The data are inconclusive. The data are inconclusive. We just know that these work to prevent headaches. Triptans and ergotamine. Abort a headache now. Oxygen aborts a cluster now. You're getting 3 to 4 a month. Prevent it with propranolol. If propranolol doesn't work, verapamil-diltiazem, or the SSRIs. Tricyclics, and you know what? As a general rule, all the seizure medications, phenytoin, carbamazepine, valproic acid, lamotrigine, phenytoin, okay, lamotrigine, topiramate, which is Topamax, a seizure medication. Topiramate's a seizure medication. Lamotrigine, Lamictal, a seizure medication. Did you know that all those seizure medications are also pain medications for neuropathic pain? Not like I bumped my arm and I have pain, but neuropathic pain, meaning peripheral neuropathy. Did you know that all of the seizure medications, all of them, phenytoin, carbamazepine, topiramate, lamotrigine, valproic acid. Did you know every single one of those seizure medications can also work for neuropathic pain? I have peripheral neuropathy from diabetes. I've tried everything, nothing worked. Neurontin, gabapentin didn't work. Pregabalin didn't work. Lyrica, which is pregabalin, didn't work. Pregabalin, new for you, I know that. Okay, didn't work. Gabapentin didn't work. I don't know what to do. Try a seizure medication. Phenytoin, carbamazepine, valproic acid. All except ethosuximide, actually. All except ethosuximide. Ethosuximide has been absent from this. Too busy using it for the absent seizures. So the thing is that all seizure medications are also work for neuropathic pain. You say, well, how do you know which is the best one? Well, you don't. See, neuropathic pain, like headaches, peripheral neuropathies, we just don't know which one's going to work. We know that propranolol is the best prophylactic medication for headaches. Why it's better than calcium blockers, we don't know, but it is. It's just the way it is. 100% oxygen aborts the clusters. Here's our headache story. A guy comes in with a headache the first time. Oh, severe, focal findings, head CT. Oh, severe, overwhelming, worst headache in my life, looks like meningitis, head CT. I got tenderness over here, steroids. All right, I've excluded the secondary cause of headache. What do I do now? Primary headaches. Band like around the head, tension headaches, give me a non-steroidal. Non-steroidal doesn't work, try an opiate. No focal findings. No aura. No visual. No focal findings. No aura. No visual. Oh! Migraines. Visual. Migraines. Unilateral. Hemicrania. Most of the time. Up! Abort the treatment with triptans and ergotamine, but not if you're pregnant or have myocardial infarctions, because the triptans and ergotamine will constrict the vessels in the heart as well. And your patient's not going to like that. I've got some good news and some bad news. What's the good news? I made your headache better. What's the bad news? I caused sudden death. Oh, look who wants everything. And that is the end of our headache.